And the things that I say here do not necessarily reflect the views of the Cleveland Department of Public Health or the City of Cleveland in any way. Okay, now that we got that out of the way, I feel like I can say what I want, right? Okay, so what the Division of Health Equity and Social Justice is doing. I just came on board at the very end of July, and it is a new division within the Department of Public Health. So in Cleveland, it's a little bit different than other health departments. Most health departments, especially in the state of Ohio, are set up in terms of the head of the health department is the commissioner, and then you may have directors of divisions or directors of programs. Ours is inverted, so we report to a director, and then we have 4 commissioners. We have a commissioner of health, so who's basically in charge of health programming and health outreach and all of our health issues and initiatives and epidemiology department, things like that. We have a commissioner of environment, and that handles things like restaurant inspections, home inspections, things like that, anything that sanitarians would do. We also have a division of air quality that monitors and works with Ohio EPA on air standards and air pollution. And the 4th division is where I come in, is brand new. And it was incepted basically as last spring due to so much attention, unrest, issues that were really kicked off by the murder of George Floyd in Minneapolis. You saw a ton of cities, health departments, corporate entities making statements around racism and inequity. And so at that time, many cities made declarations, official declarations, that racism is a public health crisis. Cleveland City Council did the same thing with the mayor's backing. And that same ordinance gave the City Council in Cleveland the authority to institute a working group, which consists of external community agencies and folks that work in different sectors to come together, create a working group to decide how will we tackle these issues from the standpoint of the City of Cleveland government and the health department moving forward, so that it's not just a statement that came out that one time. So that working group started working with council, and in the meantime, the mayor, who has the authority to create any type of program or position or initiative that he wants to, really decided he was going to create an office of health equity and social justice. He could have created this to report directly to the mayor and be just a part of the city government, but I think he was trying to be very forward-thinking and putting it in the health department. Number one, because so many of the disparities that we see on the health side of things are a result of racism, and he knew that the health department would be the most adept at working with these issues, but he also didn't want it to get lost, both figuratively and really lost, because our mayor is currently in his last term, last few months of his last term. He's not running again, so he knew if he made it like a cabinet position, when the new administration comes in, whoever gets voted in could look at that and say, we don't need this office, get it out of here. So by embedding it within the public health department and creating it at the commissioner level, it's a permanent protected position. So we can carry on the work of the health department and through the health department without fear of it being cut. The other thing to remember about the setup of our health department is most other health departments have a board of health that they are working under. So most county health departments also, there are boards of health, and they have a governing body above the director or commissioner and the workers that they report to. We actually, because we are a part of city government, we report directly to the mayor. So there's a little bit of difference there. Okay, I want to tell you a little bit about just myself personally, because I think it's warranted based on the type of things that I'm going to be talking about. I don't necessarily think that most speakers or anyone are obligated to tell you anything about their personal life or who they are, although I feel like when I'm approaching this topic, it is important for me to be able to connect with you, and in that way, it is important for you to know who I am, at least on the surface, so that you have a better understanding of where I'm coming from. So much of this work that we do, and so much of the work that you're going to be doing, and no matter what you're doing, you're bringing your everyday, authentic self to work with you, whether you like it or not. We hear a lot of talk now about people feeling comfortable to be their real, authentic self at work and at school. And sometimes that feels like lip service, right? Sometimes it feels like, well, that's what the rule is. The rule says I can be who I want to be without fear of reprisal or retribution or discrimination. But sometimes when we're in the mix of things, things happen that make us not feel that way. So I'm going to tell you about myself in effort to make sure this is a safe space. So just like I'm going to tell you a little bit about myself, I would hope that I'm not obligating you to tell me anything about yourself. I just want you to feel free as we move into discussion to understand that I want to know from you as much from your personal experience and what you think and your opinions as we want to know from what you know academically, right? Because it matters. So she told you sort of by way how I came into public health. Right out of college, I started working for the Free Clinic of Greater Cleveland. The Free Clinic was started in the early 70s by a group of students at Case Western University who at the time were noticing some things happening among their student community, but also the community around them in terms of the time period. We had a lot of vets coming back from Vietnam. We had a lot of experimental drugs out on the streets, and not a lot of resources. And it was sort of that counterculture movement where people were, feeling free to experiment with sex, drugs, and rock and roll. But when things went south, there wasn't a whole lot of help in terms of what do we do? Do you go to a traditional hospital if you're overdosing on a psychedelic drug? Do they know what to do with you? I don't know. So a lot of folks were med students, nursing students, social work students, and they created a hotline to basically just take phone calls. And it was ended up being a lot of mental health calls that they were fielding and trying to help folks through situations, whether it was having to do with drug overdoses, or bad effects from drugs, whether it was Vietnam vets that had PTSD symptoms and had nowhere at that time really to go or anyone to talk through this with, suicidal thoughts, things like that. And so this hotline sort of grew, and they thought, well, we could actually open a center and actually get some of the med students and maybe even some of our professors who are legal doctors to come in and volunteer and just to start to see people. And that is what created the Free Clinic. The Free Clinic was designed to see anyone without regard to whether they had insurance or not or could pay. All services were free. And it remained that way from 1971-ish when it started until they started accepting, it sort of has changed over and gone through some different entities and now is part of the federally qualified healthcare system. So they accept Medicaid and things like that. But that changeover didn't happen until maybe around 2009, 2010, if I'm thinking correctly. So I came in when it was still pretty much exactly as it had been in the 70s. We offered medical care, mental health care, reproductive health care, substance abuse treatment, therapy. We had a dental clinic, and these are all staffed by real certified dentist doctors, but also med students rotated through our space, and we had a ton of volunteer doctors and nurses that would do treatments under our medical director. And the way it worked is doors open at 5 o'clock, Monday through Thursday. Anyone who's having an issue walks in, grabs a number. You see the medical assistant who takes your history, and they decide where you need to go, who you need to be seen by. If 60 people walked in at 5 o'clock, we stayed until all 60 people were taken care of. And that was Monday through Thursday. On Fridays, we had a model of appointments system, and that was for our folks who had chronic conditions, high blood pressure, diabetes, that type of thing. All the people that we saw did not have health care, whether they were offered it through their jobs, but they couldn't afford it, right? Because that's a real thing, not being able to pay the employee share. Whether they had some health care, but not enough to cover the conditions that they had, because you have to understand, sometimes you get into a health care provider system that doesn't pay for things when you join them, if you already had that issue before you came to them. Also had a pharmacy, provided the meds right there on site, that kind of thing. And we also were, like a couple of different public health clinics, a place where people could get reproductive and sexual health services for free. And for teenagers 14 and up, you could get that care without your parents' consent. And there's a whole bunch of laws and rules around that and why that's legal, but it is. My role there was to head up the HIV services department. Initially, I started as an outreach worker. I had no thought about going into healthcare. I was born in Cleveland, West Side for life. Raised in the city, went to public schools. My mom, this is where the personal stuff comes in, my mom's black, my dad's white. I didn't know my dad until I was about 32. So in terms of culture, I didn't have a white side of the family. I had my mom. I had my 6 black brothers and sisters who didn't treat me any different because I looked a little bit different than them. And that's how I grew up. I wanted to go into the arts. I wanted to study theater. I was a graduate of the Performing Arts High School in Cleveland. And somewhere in my senior year, I did well in school. Had honors classes, all of that stuff. Was very good at science, not so good at math. Didn't like it until they taught me about budgeting. That's a whole other thing. Somewhere in my senior year, I decided I wasn't going to college. And I told my mom this, and this had been the plan, right? And my older siblings had gone to college, and there was no question, this is what you do. And so I told her I wasn't going. And she said, well, that's fine, but you still have to get out of my house. So I went to college. And I studied theater. And I was always really proud of myself for never changing my major. And when I got out of school, I was getting ready to get out of school, and people were like, theater? What are you going to do with that? So I guess you have to go to grad school and get like an MFA, or you're going to move to New York? How are you going to get a job? I didn't know, So I did what I was always doing through school, worked in a restaurant, quite a few of them, sometimes 3 of them at one time. And right as I was graduating, a friend of mine, a fellow waiter, gave me the paper, and there was, that's back when newspapers, that's where you looked for jobs. Yeah, it was a whole thing. He had circled this ad for the free clinic in Cleveland. Sounds crazy, but you have to remember this place was started by literally a bunch of hippies. They had a theater program, and they needed a program assistant. I was like, why is there a theater program in a health clinic? This does not make any sense. But I went to the interview anyway, and what it was a outreach sort of prevention program for teens, and it had been in existence since I was a kid at that point. And what they did was they had about 40 youth volunteers age 14 and up, and they would train them in different health issues that pertain to teenagers at the time. And are we good volume-wise? I felt like something went out. Okay. They trained them in different health issues that pertain to teenagers. So things like drug and alcohol abuse, teen pregnancy. At the time, HIV/AIDS was a big one that schools were wanting people to come in and talk about. Self-esteem issues, body image, this whole gamut of teenage issues. And so they would give them formal training in these issues, and they also trained them in improvisational acting. And what they would do is in their groups, as they would come, do their volunteer work, they would be there twice a week, and they would come up with like little skits based on the information that they were learning in their health training. We would massage those skits, get them get scripts out of them and then practice them, and we would go to schools and churches and youth groups, and they would perform these scripts, and then because they were trained, they would do the talkbacks afterward. So I came on as the assistant in this program. And in that program, I think there's some turmoil happening in my department, but anyway, the director and everyone else who worked on that program was gone in 4 months. And so I was just there, 25, with 40 kids, driving around in this giant van to different schools, talking about HIV and condoms and becoming known as the condom lady for a long time. So after that, I think I did that for that particular program for about 2 years before I was asked to take over the HIV testing and prevention department. HIV testing and prevention at that time, and it's still a little bit now, in the state of Ohio, you had the right to, because HIV/AIDS had such a stigma behind it, that you could get tested anonymously, because the object was get people to know their status without them being afraid of losing their housing, being kicked out of their families, losing their jobs. Get people to know their status so they can get treatment. Therefore, you have an anonymous testing system. So I ran that for a while. You can also get tested under your real name. Most people do it that way now. But at the time, people who even had health insurance didn't do HIV testing with their doctor because there was a whole lot of stigma around that going on your medical record. Would insurers, future insurers, carry you, treat you, pay for your treatment, that kind of thing? So it was a whole big thing. The other piece of that program was doing outreach with injection drug users, and we were the only legal needle exchange program within I think it was a 3-state area for a while, and gradually other cities got the emergency order to be able to provide that. And the theory there, that's a harm reduction model, and the theory is if you can get people who use injection drugs at that time, and it was a lot different than it is now, to come to a set site, whether it was a van parked on the street, which is what we did, or into our clinic, to exchange their needles, their used needles. We would destroy them and get rid of them like medical waste. Give them clean ones. Then the idea was that they're less likely to share those needles, less likely to pass things like HIV, Hep C, less likely then to be infected and infect their partners, family members, etc. So it was a harm reduction model, and some people would say, why would you give needles to a drug addict? They're not supposed to be doing drugs. Well, our whole model was we'll save their life first, and then we'll work on that. And it was actually a really nice conduit to get people to trust us enough to say, I really don't want to be doing this, but I don't know how to get off. Can you help me? And then we could ferry them to a safe space where they could then enroll in treatment. So that's where I feel like I formed my outlook and my understanding around healthcare. The tagline under all of our free clinic memorabilia, all of our signs, all of our stationery, there's a little tagline under that says, healthcare is a right, not a privilege. I'm going to say it again because I really want you to understand that. Healthcare is a right, not a privilege. And the other thing that I'll say about the free clinic and how it kind of formed me in terms of everyone came there. High stature people were coming because they didn't want certain things to go on their medical record, or they didn't want bills coming to the house and having family members opening it up and seeing that they were treated or at the doctor for a specific reason, and people who could not afford the health care that they needed, whether through their own insurance or through other traditional medical facilities. A lot of who we saw were people who worked. Then we would refer to them as the working poor, but these are folks that worked every day, sometimes 2 jobs, sometimes 3, but neither of those jobs added up to appropriate health care. And you have to remember, it was so important for us to be open at night. Our appointment started at 5, right? Because not everybody can take off work. A lot of people are in jobs where you don't get sick time. It's hard to imagine, but there are jobs where if you don't show up that day, boom, you're gone. They put another person in your place. It's a little bit insane. The other thing that within that work that I did the HIV prevention program for maybe another 5 years at the free clinic. The other thing where they trained us, and I feel like I'm a little bit spoiled because that was my first real job out of high school, and I was working in a place like that considered healthcare for all people to be a right. And in our training and in every single job description, in everything that we did, you had to adhere to one principle: you be non-judgmental. And so I did. I learned it. You know, if I wasn't non-judgmental when I came there, I was by the time I left, right? And everybody's judgmental about something. We all have our buttons, right? That we're the here and no further line. Like, I can accept this, but this, maybe not so much. We all have that. But there is something to be said for approaching this type of work with a non-judgmental mindset, right? And I think I'm noticing now as I look back on that 20 years, yeah, I started when I was 9. Looking back on that 20 years, the other places that I've worked, when I've felt difficulty or when I felt like my values and philosophies weren't matching up with the values and philosophies of the organizations I was working for, when I felt that rub, it was because in our practices, not necessarily mine purposely, but in the organization and how we did things, when, in my estimation, we weren't being non-judgmental, right? And I'm saying that to you because as healthcare providers, that's going to be one of the most important tools you have in your pocket. No matter what you do technically, no matter what you do, how many patients you see, no matter what your productivity is, no matter how accurate you are in your everyday, if you're not non-judgmental, you're not going to connect with your patients. And I still think in all of healthcare, the most important thing is connecting with your patients. Okay, so now that I've said all that and given you all the soapbox and rah-rah, we can go ahead with the slides. Any questions so far? All right. There are going to be some questions in here where I ask, so if I'm looking at you, nod your head, blink, let me know you're alive. You can say things. There are some points where I will ask you questions and want somebody answer me somewhere, okay? This is, as we approach this conversation, but also just in general, this is probably, I've been through a lot of training, a lot of education, a lot of leadership programs. This is the one lesson that just blew my mind and has stayed with me forever from all of that. Q-tip, quit taking it personally. We're going to talk about race. We're going to talk about racism. Racism, structural racism, is not the fault of anyone in this room, okay? So as I'm talking about these things, don't take it personal. Don't take it personal. If something that is in our history as a country comes up and it's horrible, and it is, don't take it personal. We're never going to move past it if we continue to center ourselves and say, well, I didn't do that. I had a woman, a coworker, this was just a couple years ago, because I told you guys my mom's black, but I know what I look like. You don't have to tell me. So it comes as a surprise to many people. And this particular coworker, and I had a picture of my mom in my office on a shelf right above my desk in a frame that says mom. And my mom is not a light-skinned woman. She is very visibly black. There is no question. The question was, back then, when I was a little kid, people always thought she was the nanny or the babysitter. No, she was not. So this woman is in my office, a colleague, we're talking, and she had some situations where she was working with the public in a black neighborhood. She was white, and she felt like, well, I can't say what she felt like because I don't know, but she used the term, she said, I don't like going there because they white girl me at these meetings. And I took that to mean they either discredit her or didn't take her opinions seriously, and she felt like it was because she was white. At this point in our friendship, we had not had a conversation of what I am. Because sometimes, if you don't ask me, why would I bring it up? But I do have this picture in my office, and she's telling me this. And I'm empathizing, and I'm nodding my head, and she says, I didn't own slaves. Ooh. cringy, don't ever say that. Yeah, I know you didn't, because by the time you were able to own anything, that part would have been illegal. But that's not a good look. And then she said, I think this is where she was trying to like draw me in, like to wink, wink, nudge, nudge. You and me are the same. We're not. She said, I mean, let's face it. You and I, granted, we don't know what it's like to be black. And I was like, well, kind of. Anywho, she was taking it personally. The feedback that she was getting in these meetings, she was taking it very personally. Instead of figuring out where they were coming from and understanding who needed to fix the issue that they had, and where their anger was directed. The anger in her particular case wasn't being directed at her. It was being kind of rightfully directed at her organization and their relationship with city government and not getting the things done that this neighborhood wanted. Okay, so anything that we say in here, don't take it personally, okay? And likewise, you don't have to ascribe to it. You don't have to believe me. You don't have to share anything. We can talk about things later if you want. But as healthcare providers in a diverse setting, you have to learn some of this stuff. All right, so here's some key terms to keep in mind. We throw them around a lot, and they seem to get kind of jumbled up and interchanged, but they do have their own definitions. So equity is the quality of being fair and impartial. That's just equity alone. Health equity is the absence of unfair and avoidable or remediable differences in health among populations defined socially, economically, demographically, or geographically. So population groups like we were covering earlier before me, it's not just race, right? Your demographics don't just mean race, it means a heck of a lot of things. So when we have health equity, that means everybody has equitable everything, equitable access, equitable care. This is something that we aspire to. We are aspiring to health equity. Health inequities are the flip side of that. That is systematic differences in the health status of different population groups. This is different than health disparities. Health disparities is what we kind of learn about a lot. We learn about higher rates of chronic disease in specific populations, or that's not exactly this. Disparities are more just a difference. And they may be caused by nothing or just how it is. For instance, there's always going to be differences in the health. Like if you see a life expectancy difference or disparity, well, yeah, if you're 80, your life expectancy is going to be a lot different than someone who's 40, right? If you're looking at you at the same time. So that's just a blanket difference. Health inequities mean it's a systematic difference in the health status. Justice, that means just behavior or treatment. So concern for justice, peace, genuine respect for people. That means treating everybody with a sense of justice. Everybody gets treated the same. Social justice, that's justice in terms of the distribution of wealth, opportunities, and privileges within a society. This is what you want to think about when you come across the bootstrap people. If you're bootstrap people, welcome. Bootstrap people to me are the folks when we have these conversations, they always pull out, well, just pull yourself up by your bootstraps, without regard to the fact that that analogy doesn't help for folks who maybe don't have boots, right, to begin with. I had a conversation with technically a boss of mine who was a board president. I was working in college access at the time, so getting kids in 2 school districts to college, regardless of their income status, helping them get to college or a 2-year program or Army, wherever they were going after high school, that's where we were trying to help them get. And his philosophy as the president of our organization was, number one, whether or not you advance to college or other education after high school really just depends on how hard your parents are willing to work and sacrifice for you. Not really. So we had this conversation about The way that your family was able to accumulate wealth is very different from the way that my family was able to accumulate wealth. And the way that my family was able to accumulate wealth was different than his, not because of something that my family did or didn't do or didn't work hard enough. There were literal laws that said you cannot accumulate wealth. You cannot own land. You cannot pass land down to the next generation. You cannot go to school. In our history, there were laws that said certain people, most of the time by virtue of the color of their skin, could not do A, B, or C. So it's a little bit different. And that's what social justice is. It's about understanding those inequities, really, but understanding that where it comes from, and that's how you start to learn how to fix the problem. Okay, so in public health, this is a couple more definitions for you. Public health refers to the health of the population as a whole, especially as the subject of government regulation and support. And again, we're thinking about as a whole, we live in a society, we participate in certain acceptable norms, rules, things that we ascribe to, that's for the good of the whole, right? So when we're talking about public health, it's more about, it's not the individual treatment of just one person. It's sometimes when we talk about just health, right? Our current system of public health, and public health, are generally informed by social norms. Those norms can both be informal understandings that govern the behavior of members of a society, which we're all members of the society. So that can be informal, not something that's a law, or it can be codified into rules and laws. So we have some things that are just accepted. This is the way of life, like merging. Come on, get with me, just merge. Or actual laws. So that's going to frame a little bit of our talk. The other thing that's going to frame our talk is just a little understanding of social determinants of health. This is from Healthy People 2030, which you can see on health.gov or cdc.gov. Social determinants of health are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes or risks. Right now, they're defining this into five areas. When I started, it was like 10. But they've condensed some things. So we look at economic stability, and there's a whole mess of things that determine whether or not groups of people have economic stability. Education access and quality, healthcare access and quality. Because it's one thing, and I'm so glad they added that quality onto it, because it's one thing to say everyone has access to education, but really let's look at the quality, right? To say the majority of people have access to healthcare, but really let's look at the quality, right? Neighborhood and built environment, so those things that happen in the outside world, as well as in these buildings, in your homes, and social and community context. So that encompasses a lot of things. The criminal justice system is in there, laws, social norms are in there, any kind of rules and regulations that filter out into our daily lives that cause other issues are in that. So understanding the difference between equality and equity, you probably have seen some version of this before. So equality is where everybody has the same thing. Everybody's got that one box, it's the same height. Who's being helped there? Anyone? Who's got it good in that scenario? The first one. The first one. The second one's got it okay too, but by virtue of the fact that they're already a little bit taller, right? And third person there, he's, thanks for the box, but I still can't say anything, right? Equity is distributing resources based on need, right? So we can see that first young man there, he didn't even need a box, but he had one, right? Okay. Second person, still good, right? Just needs one box. can see. Second person actually needed 2. That makes a little bit more sense. So that's your main difference between equity and equality. And then the third one that they've added is empowerment, which is what's gone. Right, the fence, the barrier is gone for everyone, right? So maybe that's what we really should be aspiring to, is removing the barriers for everyone, right? The other thing that we talk about with equity is try not to think of equity as giving special treatment to people, and that's another argument you hear. Same as pull yourself up by your bootstraps. It isn't special treatment if you can see the distribution is equal, right? This is equity. This is about putting the resource to where the need is, right? Okay, so health inequities are defined as systematic differences in health status of different population groups. So systematic is done or acting to a fixed plan or system, so it's just part of this is how we operate. And then past policies have results in the here and now. So I want you to think about that in terms of the way that things were set up systems-wise. Some of those things have been changed, right? However, we still see the effects of past policies and what we're dealing with today. The other thing that I wanted to make sure that we're getting a little bit clarity on is these issues are not, even if we're talking about health inequities, a lot of health inequities, the root cause isn't a health issue. It's oftentimes an environmental issue or a law issue, really, that affects someone's health outcomes, which is one reason why I'm pretty intrigued about the division that I'm working in now, because it's housed in the health department sort of to protect it, and because we're dealing with the after effects, right? A lot of times when we have these huge systematic issues, it gets dumped on the healthcare system or on public health, but the origination of the problem wasn't a health issue to begin with, right? The effects are often health issues. So just keep that in the back of your mind. What are some health inequities that we hear about today? Or you can use examples from the disciplines that you're going to be working in as well if you choose. What are some health inequities that you can think of? Use your mic. Oh, should I go? You're standing on the pad. You can use the mic.
Elderly?
So you mean them as a population that is underserved?
Yeah.
Okay, yeah, there are several health inequities along services to elderly populations. Yes, anything else?
I was going to say reproductive health for women.
Can you expound on that a little bit?
Not to be political, but today what's happening, the barriers that are being put up for women and people who identify as a woman.
Yeah, so when we have laws being created that actually create barriers to specific healthcare and healthcare procedures. So that limits specifically one type of people's access, right?
Yes.
It affects one group of people. What else? What are some other health inequities? In general, access to healthcare is a big one. I think one understanding that we have to think about is the fact that in our country, the majority of, we have a paid healthcare system where you have to buy healthcare insurance to be able to participate most of the time in the healthcare system. And it's tied to usually your employment. So if folks are unemployed, they also lose their health insurance, which in majority of other countries, healthcare is not tied to your employment status. It's a right. It comes with the territory of being a citizen, being a resident, being a human on this planet. So about 1 in 10 people in the United States don't have health insurance. That's actually kind of a lot, if you think about it. And that, when we say health insurance, that doesn't mean just folks who get health care through their employer. When we say who's covered with health insurance, we're talking about Medicare and Medicaid as well. So that's 1 out of every 10 people don't have any of that access, right? Don't have Healthy Family, Healthy Start, don't have any access to health care. Here's where it gets important and how we start to think about who's engaged with the healthcare system and how that affects our overall health as a society. People without health insurance are less likely to have a primary health care provider. So are they getting regular checkups and physicals? If someone doesn't have health insurance and doesn't have a primary health care provider, when do we see them in the healthcare system?
Emergency.
In the emergency rooms, yeah, when something happens, when something goes horribly wrong, right? And does that help us with prevention? It does not. This impacts important services, especially preventive care, and I put that little piece in bold because so much of the work that you do, everyone wants to see a patient come in that's doing all their things right? We love that. When they're either not sticking to their plan or they're not coming to see us or we don't have them to begin with, it's not going to be a good healthcare. It's not going to be a good outcome for them. We don't have any tools even to do the things that we're trained to do to help prevent a situation, right? Your healthcare system stands ready to fight every kind of disease known to man, every kind of disorder, illness. We can fight things before they happen, and that's why they say in this country we have the best healthcare system in the world. Caveat, we have the best healthcare probably in the world. It's very, very advanced. We do not have the best healthcare system if less than 50% of people can actually access it, right? I think it's around 48 that are accessing it right now. Access is impacted by lack of a primary care doctor. It can be impacted by travel or distance. If you live in a rural area and there aren't any hospitals nearby or you don't have a clinic nearby, that's going to impact how you access health care. Being able to get time off from work, we mentioned that. Ability to afford copays. Even if you're working and making a decent salary and you're buying into the healthcare that your employer offers, and let's say out of your check on a monthly basis, they're taking about $250 to help your share of the healthcare. But on top of that, you also have to meet a $5,000 deductible in a year. That was my last job. I didn't stay very long. Always ask those questions up front. What's the deductible? Before you sign on the dotted line to take a job, figure out what their healthcare system is. That's a lot, right? So that would keep people from participating. And also lack of childcare. Not only can some people not get a day off work to go to a doctor's appointment that you might have to drive to. Maybe it's not just, I'm going to run over here to the doctor, take an hour, do it on my lunch break. If your wait time at the doctor is an hour and a half, it's also far away. You might have to take a whole day. And if that does not coincide with your child care situation, you're probably just going to put that off until you really have to go, and it's an emergency now, right? And sometimes we end up seeing people engaged in the healthcare system when the health issue that could have been avoided is way out of hand. And that's not cost effective for anybody. Not the hospital systems, not the patients, no one. Okay, so when we talk about health inequities being impacted by past or current policies and practices, you guys gave some good examples, but historic processes, sometimes policies we can say, when we think about, especially around race or even around income level and things like that, there were some terrible practices, terrible policies that were actually written into law a long time ago. And sometimes we can feel like those problems are taken care of if the law is changed, right? So when the law is changed, does the problem go away immediately? No, it doesn't. So that's why I want to take a look at historic policies. And, a lot of times when we talk about racism, people say, well, that was a long time ago. Why are you still talking about this? There are no slaves anymore. There are, but not the same way that we knew it. Or we can fall into, again, this is where I'm going to hammer home that being non-judgmental. We tend to fall, as a society, into the thinking that when people have poor health outcomes or people have poor living outcomes in general, that is their fault. Well, you should have just went to school. Well, you should have just gotten a better job. Or, well, you should have just did what the doctor told you. Or, well, you should have just complied, right? And it's not that simple. It really isn't that simple. If it was that simple, all of us would be living the high life right now, right? There are some things that are in place. Sometimes the laws itself get knocked down and get corrected, but the effects, we have to have something in place to care about the effects. And sometimes those things take generations to clear up. I put the Social Security Act of 1935 up here. You're welcome to look it up. I didn't know this until a few years ago, but it makes so much sense now. When I talked about what it means in terms of how families generate wealth, historically, right? My same friend who I would have these conversations with, my former boss, when he said it's really based on how much your parents are willing to work for you and sacrifice for you. And one of his other arguments was that his grandparents were immigrants. And so when they came to this country, they had nothing. And they worked, his great-grandfather worked, established themselves, was able to buy a plot of land, started a business, was able to pass that business and his land down to his son. They were able to put my friend and his brother through college. All good. Yes, very good stuff. However, like I said, it's not exactly the same as being in this country and actually having laws that say you can do none of that stuff, right? So with the Social Security Act of 1935, this is, to my mind, particularly heinous. When Social Security, when the act came about, this is actually what created the middle class, because it allowed for folks who were working to set aside money. And the idea was, if we're taking money, kind of how we take taxes out of your paychecks, and the federal government stores it away so that when you retire, you're able to get that money back to have some income to live on. This is what created the middle class in the way that prior to this, generations of families, so if you were middle-aged, working couple, you were raising your children, you were also, usually it was just one person working, usually the man in the household. You were raising your children, paying for your living and their living. You were also, more often than not, taking care of your parents, right? Because we didn't have any kind of money set aside for folks after they couldn't work anymore. So this actually establishes the middle class by saying that if this family has one income and they're raising their kids, they don't necessarily have to provide for their elderly family members because they're sufficient and provided with the money that they worked for to be able to retire, and they're sufficient. This allowed these working people to save money and put it away. So saving that money and putting it away allowed them to invest it, whether it was in their kids' education, whether it was in buying a home, which then once you buy that home and it's paid off, that's a piece of property, it's an investment. You can put that goes to your family, your kids, their kids, when you're gone. When we created this act, they did something very sneaky. They wrote a clause in there that said, Social Security does not apply to folks who were domestic workers, which is like housekeepers, maids, nannies, babysitters, or farmhands. In 1935, who do you suspect were domestic workers and farmhands? especially in the South.
African Americans.
Yes. So, by writing that in there, and the reason why they did it was to get the law passed, they had to swing Southern states, and they knew Southern politicians weren't going to vote for it if it didn't have a way to segregate black people out of the system. Not to mention, they didn't want their folks who owned farms, employed domestic workers, to go against them and feel like they have to be bothered with the system that helps to pay Social Security for their workers. And it was like that into maybe the early 60s. So when the rest of the country had a middle class bubbling up and boiling up and growing, and you saw the boom in the 50s of people buying cars, buying homes, sending kids to college at record numbers, right? Not us. So I bring that up. Segregation impacts segregation policies. These are past policies that would be illegal today. Things like you had black-only hospitals, white-only hospitals. You had people who would be in something as severe as a car wreck, being taken to a hospital and told, I'm sorry you're bleeding to death, but you have to go to that one down the road. That's a terrible policy. That doesn't happen now, but it says something about what we're doing now in terms of trust of the medical system. Paid maternity leave is another one. We are nowhere near other countries in terms of paid maternity leave. Many other countries let you split up your maternity leave pay between moms and dads. We give 6 weeks paid if you work 30 hours or more. So if you're part-time or 25 hours, you don't get it. And 6 weeks isn't a lot. Most other places are giving 3 to 6 months. Makes a difference. We talked about this a little bit, so I'm going to skip ahead. We do see the effects of bad policy on systems today. Even if the laws get struck down, the effects are still here. Okay, so let's consider racism is the belief that different races possess distinct characteristics, abilities, or qualities, especially so as to distinguish them as inferior or superior to one another. This is how we define racism, right? Those beliefs are thinking that anyone is inferior or superior. We're not that far away from examples of that. This is a book. You can come look at it during the break if you want. It is a geography primer. I found it at a flea market in Pennsylvania on my way back from Pittsburgh when I was about 21. And I don't know why I bought it, except that I was appalled by it. So I understand something about textbooks. It might be a little bit different now, but in my day, I could get a textbook that my sister had 5 years earlier than me. My sister who had it 10 years earlier than me could have had the same book, right? So when you adopt textbooks, it's not like a one and done. You adopt them for years at a time. So this book is from 1905. It's a geography primer, so like your social studies book. It's about 3rd grade level, 3rd to 5th grade maybe. And in the geography primer, you talk about places and the people that live there and what they do for a living and that kind of thing. And I just want to read you a little bit out of this book. You can come look at it later, just to get the idea. Sometimes when we think about how does the past affect us now, think about sometimes, for me anyway, I don't know, maybe your generation is different, your grandparents, your great-grandparents, sometimes they say some things that are really embarrassing, right? That you can't believe they would say that because it's not appropriate. Some things are sexist, some things are racist. How could they believe this? Well, they were actually taught it in school. So if this book was from 1905, the last date written in it is 1909. Let's assume it was kept to 1920, right? So my grandmother was born before 1920. My mom was born in 1940. So I knew somebody who could have had a book like this in their classroom, right? So we know better right now. When you know better, you do better. So nothing should be as explicit as this, but you can start to see if someone was in the 3rd or 5th grade, and remember back then at the turn of the century, high school graduation rates were like barely 50%. no one was really enrolled in school past 6th grade or 8th grade in terms of the larger country because we expected kids to go to work. You had to work farms, you had to work factories, that kind of thing. It was very common to not finish school. Not really until we got past the war, 40s or 50s, did high school enrollment really increase. So I'm going to read you a couple things. And just look at the differences. They start out by explaining that in the United States there are different types of people, and not everyone is the same color. And then they go on to describe each type of people. And they start with the white race. The people of the white race are fine-looking, their bodies are well-formed, their foreheads are high and broad, their noses are straight, their lips are rather thin. Their hair, which may be either light or dark, is smooth and often wavy. It is not kinky or woolly like that of the Negro. It is not coarse and straight like that of an Indian. The people of the white race are highly intelligent and are active and industrious. And then it goes on to list some of their accomplishments. And for this handsome, high forehead, highly intelligent looking, handsome person, it is William McKinley, just so you know. When they move into the other races, they describe what they look like. They describe the yellow race is the term that they use for Asians, and they specifically talk about Chinese and Japanese. This is what they said about, one of the things that they say about Chinese people. They say they're very industrious. Many Chinese have sailed from China to our country. Here they work as servants and do other kinds of labor. They receive small wages and can live cheaply. In many cities there are Chinese laundries. To assume that people are okay being paid nothing because they can live cheaply, that's going to be a little bit of a bias. I won't read you all of this, but I do want to read you a couple of things. I just want you to get the idea and get the notion that it's very clear the bias, right? We're holding up one race over all the others. This is what they say about the black race. The savage Negro tribes have many strange customs. They file their teeth into points and wear heavy rings in their noses, ears, and lips. They have no schools or churches. It's just lying now. They pray to ugly idols made of stone and wood. It also says that, this is insane. The Negro has learned to work for wages and take care of himself. They are growing more and more intelligent and have so improved that it is hard to believe that they are descended from savages. I want to read you one more line. This is among things that they had to say about Native Americans, in which we know this has been in the news recently. This is as they're wrapping up their description of Native Americans after calling them cannibals. Most of the Indians in this country now live far out west on large tracts of land reserved or set aside for them. That's an interesting take on the matter. It is hard for the Indians to learn the ways of white men. There are some schools where Indian boys and girls are being taught so that they will grow up more like white people. This isn't that long ago, right? So we can understand that what your great-grandparents, what my grandparents learned in school, they probably told their kids, right? This is how we get a system of beliefs, right? This is why what we learn now conflicts with what our great uncle says at the holiday table that is so offensive. I just want you to be able to connect and understand how and why this might happen. Okay, so we talked about racism as a public health crisis. I'm going to skip this slide, although it'll be here. But we know that racism is a huge ism that has to do with our outcomes now today. Even though many laws around segregation and racism that were legalized and systemic, the laws have been struck down, the effects are still here. This is affecting our engagement in healthcare systems. This is just a little bit of background to show you that even though a larger majority have health insurance now than we used to, many people still aren't engaging in it. We're around 48% of people who say that they actively use their health care The rest of us are either not in it, or if we have it, we can't afford to use it. So I'm going to skip these questions because we'll have time to discuss that later. Right now, in the midst of the pandemic, which we have a vaccine for, several vaccines for, and we talk about vaccine hesitancy or why people don't want to take it. And please understand that when we think about disparities, you can't just look at populations and say, well, they don't trust the healthcare system because of something historical that happened. It's not true. There is a little bit of, we'll just use African Americans as an example. And we talk about the Tuskegee syphilis experiments. Yes, that is a huge reason why Black people don't trust the healthcare system. Howsoever, it is not the only reason, and we are seeing hesitancy and distrust of healthcare systems for things that happen today. The way that your mom or your dad or someone that you know says they're treated when they go to the doctor, says they feel discriminated against. That carries more weight than any historical thing could ever. So these things are still going on, still happening. And if you look at, these are folks who are being polled on the way out of getting a COVID vaccination, and ask them if they were unvaccinated and hesitant to get vaccinated. It's across the board, almost the same percentage-wise. I think the lowest one there is AAPI, and that's actually a group, Asian and Pacific Islanders, actually a group that has more, in this country, more chance to be engaged with the healthcare system because they're more likely to have health insurance in today's climate. But for the most part, hesitancy is across the board. It's not just about one group of people or another. That hesitancy can sometimes be explained by barriers. Were they too busy? Could you not get off work on the days that the vaccine clinic was in your area? Did you need transportation to get there? That kind of thing. So there are other reasons keeping people from this process. And I want to get to this. So when they asked these folks about effective messaging, who they thought was the most effective person to say, you should get the vaccine, or answer any questions for them, explain the process to them. They wanted to hear it from their personal doctor or primary care physician, which makes sense, it tracks, right? But we still are dealing with 50% of people who don't have a primary care physician. Do you see where we can't get around this vaccine situation if we don't have engaged, trustable people in the healthcare system? And that just ranks their other reasons they would like to hear it, if not from their own doctor, from any doctor or nurse. They want to hear it from their family members and friends who have had it done, that it has some sway. Where they want it to get it done. Some people, and I heard this with elderly populations across the board, I'll just wait until I can get it at my doctor's. Well, we're not there yet, because the way that these vaccines work, they have to be refrigerated in a very, very specific way, so most doctors' offices can't accommodate this. But they still want to hear it from the healthcare provider. They want to get it from their doctor. People want to be engaged. People reporting poor treatment by medical professions, it's actually very low, relatively low, 28%. So that's not the issue either. We'll skip this part, maybe we'll look at it at lunch. But I say all that to tell you this. You are in a really great position to build trust among healthcare providers and their patients, right? And building trust is the quickest way we have to build engagement. The more people are engaged, the more they trust the healthcare providers, the better off that societal health is going to be, right? So you have something very important to do. You have to, number one, remember that healthcare is a right, not a privilege. And also please remember that you're going to be in a position of service. You have to serve the folks that are brought before you, right? Okay, I really have to wrap it up, or they're going to kick me out and never invite me back. I'm going to stop here. Thank you so much.